We have about 15 minutes for questions, and I have so many questions. I really have a lot of questions for Dr. Judge. And I want to start with I just want to get it out of the way. What's your dose of tafamidis? What do you use?
You're referring to the controversy of 80 milligrams versus 20 milligrams, and then, of course, the study wasn't powered to interpret a difference. Then the manufacturer said, well, those 4 20 milligram tablets are hard to use. Let's make a 61 milligram version, slightly different. The oral bioavailability is similar to 80 milligrams. So 61 milligrams is the recommended dose. For most people, particularly those with familial disease, the higher dose makes more sense. And there's limited data that shows better outcomes longitudinally in late phases. However, those data, as I mentioned, are limited. My VA patients, for instance, I'm always told the VA will only pay for 20 milligrams, and my answer is great, particularly if they have wild-type disease. It's expensive. That's a good cost-saving measure. 20 milligrams for wild-type disease is typically adequate.
Okay. I have two treatment questions now, and this first one is directed to Doctors Milani and Judge, but I welcome everybody's input. Both of you in your talks mentioned AT3 as an emerging therapy, and this is a SAP-directed therapy, and first of all, can either one of you just sort of talk about what the rationale for SAP-directed therapy, and then why would AT3 expected to be different than previously studied SAP therapies? And I guess it leads to the next question: is did we just give up on SAP as a target too soon? So who wants to tackle that first?
Dr. Milani?
Please go ahead. Go ahead.
Oh, sure. So great question again, and I think the answer is the last comment that you made, that we probably gave up too quickly on anti-SAP therapies. The challenge for any of these new therapies is that we don't know the safety issues, and the complicated monitoring regimen, I think, was part of the rationale for giving up on the earlier GSK therapy for anti-SAP. It also requires CP-HPC to remove the circulating SAP in the blood so that you can then target it in the diseased organs. I'm hopeful for positive results, but we certainly need the trial data. It's another good reason to recommend your patients for clinical trials.
Dr. Milani,
Yes.
SAP therapy, SAP therapy, this is one of the only treatments we talked about today that had relevance for AL amyloidosis and ATTR amyloidosis. Can you explain?
Well, one problem, I think, is that we have few data regarding the issue related to the stop of the clinical trial. So we probably may ask to have more information about that in order to move forward. The second possible problem could be that the SAP scan is not available worldwide, and so this could be another possible problem. But of course, if new options will be available soon, it is really important for all our patients.
So I guess what I was getting at, SAP is it's a common target among all types of amyloid potentially, right? So it's different types of amyloidosis all have that as something that you could. So theoretically, an anti-SAP therapy could be a pan-amyloid therapy, correct? There's a question from the audience about IgM amyloidosis. And we've very much focused on non-IgM AL type amyloidosis, light chain amyloidosis, but for IgH or IG or mixed heavy chain, light chain, not IgH, but heavy chain, light chain amyloidosis, what's our preferred therapy? Is it different?
What you're looking at is what the clone is, right? So if it's a plasma cell, then it's the daracibord. If it's more of a lymphoplasmacytic kind of a lymphoma, we tend to use bendamustine with Rituxan. I don't know what others are doing.
Yeah,
Yes, we are
follow
doing the same.
Right.
We also use the same approach. The problem is that for Igm amyloidosis, our experience is that these patients tend to have a very disappointing hematologic response and do poorly, and it's difficult to, if you fail bendamustine with rituximab to use ibrutinib, it's quite difficult because they get atrial fibrillation, they disorganized.
Which is surprising in the sense that, for otherwise uncomplicated low-grade lymphoma, you have the expectation of a very high complete response rate. I mean, with therapy, right? For at least initial therapy. So, okay. We have a question from the audience, live question.
Thank you. It's for Dr. Judge. You were presenting your algorithm, and you mentioned that you defended endomyocardial biopsy as being safe, and the TTR at the end to differentiate between senile and mutant TTR amyloidosis. But in Brazil, it's a big country. We have a lot of L30 met, and sometimes getting a endomyocardial biopsy is not available everywhere. We do it at our center rather routinely when indicated, with a very low complication rate, as you indicated. But if somebody is at a stage a little bit higher in the algorithm and they do sequencing and they do find the mutant TTR, do they still need an endomyocardial biopsy?
Wow, that's a great question. And the algorithm that I showed was not certainly at all to address the question that you're asking, which is your patient with V30M, a mutation particularly in Portugal and Brazil, which shows up in the early ages, so 30s years of age, with neuropathy, and often early on without cardiac involvement, although cardiac involvement is later. A heart biopsy would not be helpful in that context, particularly with neuropathy without evidence of heart involvement. So in the absence of a monoclonal gammopathy, in the presence of a TTR mutation and neuropathy, I think you've made your diagnosis. I would defer to a neurologist as to how much nerve conduction study abnormality you would need to see, or what other exclusion you'd need to have. Say, if they have diabetes, is there another source of neuropathy?
But these are patients who do have cardiac amyloid by imaging or by some kind.
Yeah,
and they do have programs to sequencing the gene that are much sponsored most of the time is by companies. So it's a lot easier for the physician to just get a voucher or sequence the TTR gene than to, especially if they're in a more remote area or not in a big city, to send the patient to a referral center to get an endomyocardial biopsy. So that's why I asked the question.
Well, I think, let me defend my algorithm a little more then to say that if they have a monoclonal gammopathy, then they still need an invasive answer to discern whether it's light chain or familial disease. And the light chain question is the important one in my mind. If they don't have a monoclonal gammopathy, as the algorithm showed, then non-invasive imaging strategies should suffice.
I have a question for Dr. Havasi. And Dr. Kasturitis also brought up the renal staging system that we use to predict risk of dialysis-dependent renal failure. And the original paper on this was a European paper that showed that patients with stage 3 renal involvement have an extremely high incidence of going on to develop dialysis-dependent renal failure. But Dr. Havasi, you and the Boston group published very different results, still showed an ability to, like a prognostic discernment between the different stages, but the rate of dialysis was much, much different. And so my question is, do you think that's because of differences in treatment or because of differences in patients? Both.
So there was a big difference between the patient population they looked at and we looked at. So they looked at all comers. Doesn't matter if someone was not a stem cell transplant candidate. And our group actually looked at only the stem cell transplant patients. So obviously it's a very different population because the patients who are eligible for stem cell transplant, it's about 20% of all comers, they are the healthiest, they are the ones who are in better shape, right? So their outcomes are much better. And just to mention that the staging system, not to hide it from people, we have two parameters. One is proteinuria, 5 grams, less or more, GFR 50, less or more, and if you have none of these, then you have stage 1, stage 2 is one of them, stage 3 is both of them.
I'll just throw one statement. So again, you alluded to it, but the patients from Europe could have had significant heart too. So the combination of heart and kidney kind of gets you to badness, whereas if your kidney and your kidney's not so great, but you don't have significant heart, you're in better shape. I think that kind of makes the difference.
I agree. Any other thoughts from our other panelists?
Yeah, I think the issue of renal response is something that we have not, concluded yet. And I think that there are two very interesting posters. One of them related to the depth of renal response that you can get and when you can get it and what it means. And I think we have to learn a lot about this from this collaborative study in AL amyloidosis. We have to be patient, and unfortunately for some patients, and perhaps Dr. Havasi can allude to that, they are destined to go to dialysis. I mean, they have so much amyloid in the kidneys. They start with 20 grams of proteinuria, they get a renal response, but they go to 10 grams of proteinuria. Still, this is too high, and we see renal function dropping. So sometimes the damage in the kidneys or in the heart is so bad that we cannot expect, even with complete hematologic response, to see an improvement. And we have to prepare our patients for that.
Is there, I think you're clearly right. We all see patients like that who have a great hematologic response, but the cycle of kidney damage that's triggered by proteinuria that doesn't resolve or partially resolves but persists and it then itself is toxic to the kidneys. Is there any strategy, Dr. Havasi, to mitigate the damage of ongoing proteinuria in these patients?
I wish we had something definite. We do use ACE inhibitors and ARBs when they are not contraindicated, just because they work in diabetic nephropathy and other proteinuric kidney diseases, but no one ever checked if they work in amyloid. But we do recommend it, and we hope that they decrease glomerular pressure, decrease proteinuria, and as a result, the toxic effects of proteinuria on the tubules will be lessened.
So would you recommend that that class of medications in a patient who is not hypotensive and can tolerate them if they have proteinuria?
We do that.
Okay.
And they don't have, also they don't have significant cardiac. So it's not just the hypotension, but you want to just be careful with cardiac output.
So we're talking for some very few patients.
Right.
I can only imagine very few patients tolerating ACE inhibitors like that. Yeah.
Right. I think you have to be very careful with angiotensin because chronically intravascularly volume depleted people are angiotensin dependent to keep their renal perfusion. So.
It's very tricky.
I think we're just running right up to the edge, but I'm going to have two more questions. I want to, and they're both, again, around the edges of what hematologists think of, but I think it's important that we familiarize ourselves with the breadth of amyloid. First, Dr. Havasi, what should hematologists know about ALEC2 amyloidosis? And are there specific populations in whom we ought to be thinking about this diagnosis right out of the gate? How common is it compared to AL or ATTR?
So, if you look at the data, it's very, very rare. So obviously, if you look at the data that comes from
The data's bad or the disease is bad?
Rare.
Rare. Sorry,
Rare. Oh, I thought you said
very,
bad.
very rare.
Oh, I thought you said bad.
Not
I was
bad,
like,
not
okay,
bad,
yeah.
rare.
Mm-hmm.
So if you look at samples that were sent for mass spectrometry, in those samples, we have a high percentage, but don't forget, 99% of the times when it's like AL, we don't send it for mass spec because we get the diagnosis just by the regular tests using primary antibodies on the protein. So it's extremely rare. It's said to be more common in Spanish populations, might be. But we have so few patients. Now, how bad is it? It's not a bad disease compared to AL. Most of the times it's slower progressing. And sometimes we see lots of protein, sometimes we see very little protein. So it's a very diverse clinical presentation, what we see. But I have to say that it's not a common thing. So don't think that we will see it left and right.
So I think specifically Mexican population?
Mexican. That's what they say, but then, we've seen it. We had a Persian patient, for example, and, so we see in other
Some other
ethnicities.
pockets, First Nation.
So I don't know if it's real or not, but that was the originally, that was published, that it's more common in the Mexican population.
All right, and the last question, because we're right up to it. We talked about gene silencing therapies in ATTR, specifically patisiran and inotersen, both of which are approved for hereditary ATTR with neuropathy. And the question I have is, for Dr. Judge, is are these agents being developed for cardiac ATTR with or without mutations, or are there I think there are second generation products that that are coming pretty quickly, and those are being studied in cardiac ATTR2. Can you comment on that?
Absolutely, and great question. Vutrisiran has been studied both in cardiac and neuropathy, ATTR, and the first-line results are out, top-line results, and I look forward to seeing more data, but looks exciting. And then eplontersen is another GalNAc long-acting silencer, and the second generation of silencers we hope will have a longer half-life and better safety and have similar or better outcomes in larger populations. You're absolutely right. The prior studies didn't focus on the heart. These do focus on the heart, or one of these dudes.
Right. Okay, we are a couple minutes over our 10 o'clock ending time. I would like to thank all of our speakers for excellent talks. I'd like to thank Dr. Milani for logging in from overseas. Thank you so much, and your talk was excellent. Thank you to all of you. I hope this was useful. You can tell us whether it was useful by filling out your evaluations, and those evaluations do need to be filled out in order to claim CME credit, so please do that. And please let us know if there are any other questions about the symposium. Thank you so much for attending this morning.